Okay, so getting started, does anyone have any questions from the first set of lectures? Yes.
So for classification, what would that be considered? Like, can you give an example?
Like a classification of a drug?
Yeah.
Okay, so classification would be something like, we talked about different fluoroquinolones. So fluoroquinolones would be a class of drugs, right? You could kind of go even higher up than that. You could say like, antibiotics or antimicrobials, as a class, but then there's a lot of kind of subheadings under that. But typically when it's like drug class, I would say something like the fluoroquinolones, beta-lactams, cephalosporins, I can consider drug class, things like that. Make sense? Any other questions? Yes.
Some of them not have a class?
Some of them are kind of one-offs, and they may not have a specific class that they fall into. Those ones are just kind of things you gotta just know the one-offs, the unique ones, rather than being able to put them into a class. So for example, when we get to antihypertensives, we'll talk about the renin-angiotensin system and all the medications that kind of fall within that category. The ACE inhibitors are nice because there's a ton of ACE inhibitors you can kind of lump into one pile, but there's a renin antagonist called aliskiren, which is kind of a one-off, unique by itself. So you have to kind of learn separately from the other ones. So, yes.
So along the same line, so like an aminoglycoside and a macrolide, would that be considered the class?
Yeah, so you can consider the macrolides to be a class, and then under that you would have things like erythromycin or zithromycin. For what was the other one you said? Aminoglycosides, you'd have gentamicin, tobramycin. Yeah.
So would like aminoglycosides be like a subclass of antibiotics? Because would an antibiotic be the class? Or?
I mean, the nomenclature isn't so important as long as you can kind of group the medications together, because you'll know that an aminoglycoside is going to be an antibiotic, right? Just based on the classification that you're giving it as being an aminoglycoside, that you know what that drug does, right? Just like fluoroquinolone or what have you. Cool. Any other questions? Yes?
I have a question about the two viral medications. So the keratoconjunctivitis is from herpes, and then the other one is also a herpes infection? Herpetic keratitis?
Yeah, so probably a little bit of differentiation there. Obviously, I'm not real big, and I'm not, an ophthalmologist, so I don't get that deep into it. But yeah, so you'd have basically your ganciclovir that would only be used for something like cytomegalovirus, versus the trifluridine we talked about could be used for something like herpes, right?
And the cytomegalovirus is a herpes virus?
No, it's a different type of virus. Yeah, it's a type you would see with someone who has like pretty significant immunocompromisation. So someone like like full-blown AIDS or severe neutropenia related to cancer, things like that.
And then for the fluoroquinolone, you said there's a high risk for pseudomonas, or don't we use it to treat pseudomonas?
Yeah, so if you're worried about that there's a high risk for pseudomonas, then you would want to use a fluoroquinolone to treat that. So it's not at risk for causing pseudomonas. If you think the patient's at high risk for having a pseudomonal infection, that is the one that you would want to go with. Yes?
So indications for it's like ganciclovir?
Ganciclovir?
Ganciclovir, you have it listed as hepatic keratitis, and for the other drug you have keratoconjunctivitis due to herpes simplex virus.
Okay, so then you could use...
Are those interchangeable terms for the same disease?
When I was going through Goodman and Gilman's, they had them listed as two separate ones. Honestly, I'd have to look it up to see if they're really one and the same or not.
Okay.
Yeah. That's what your pathophys class is probably for, right? Hopefully. I just talk drugs, that's all. Any other questions? That's it for you. Okay, moving on, we'll continue talking about ophthalmology topics. So we talked about bacterial conjunctivitis. Now we're going to talk about more on the allergic conjunctivitis and how you might treat that with different medications. So it's important to know some of the pathophys behind it, so that you know which medications are going to be effective for that pathway. So normally when you're having an allergic response, you're going to see that histamine is going to be one of the main mediators that we can target with some of our medications to help decrease a lot of this inflammation that's happening. So we know when there's some kind of inflammatory response that's happening, like say you go around, there's a lot of pollen outside, it's springtime. If you know that's going to be triggering you, this is what's going to be happening. Typically you have two main immune cell mediators that are firing off here. So you're going to have your mast cells and your basophils. And they're releasing all kinds of different cytokines, which will include things like IgE antibodies. You also have activation of things like tyrosine kinases and whatnot. And then really the big thing we're looking at here is the release of these cytokines, including histamine. You'll have things like platelet activating factor, leukotrienes and whatnot. These same things will come up anytime we're talking about an allergic reaction, especially when we're talking about things like asthma, reactive airway disease and whatnot. But the big thing here you're seeing is that it's leading to a lot of vasodilation. Right, so those capillaries are becoming more permeable, so they're opening up, they're getting bigger, that's why they look so red. You're having a lot of swelling and itching associated with that as well. Again, just kind of a picture to show kind of what we were saying. So here you can see a degranulated mast cell, how it's releasing a lot of things like prostaglandins, even like things like tryptase and heparins. That's going to help lead to the swelling of the blood vessels, the vasodilation, and also lead to that kind of that capillary leaking that's occurring. It's where you have the edema happening there because the vessels are more leaky, so fluid's kind of coming out, and you have that there. Histamine is going to be the main mediator that we're going to be focusing on when dealing with the inflammation here. You'll see that some of the medications we'll use will target a little bit higher upstream. So you'll see that some medications will be mast cell stabilizers, and they'll actually be preventing the mast cells from degranulating in the first place. But then on the other hand, once the mast cells have already degranulated, you can't really do anything to kind of put the magic back in the box, so to speak. So you have to deal with the cytokines here. You have to deal with the histamines in order to help reverse some of these effects. So the medications we'll use, the first ones we'll talk about are going to be our H1 receptor antagonists. So there being an H1 receptor, it stands to reason there's probably other types of histamine receptors, namely H2 receptors are the other big ones we'll talk about, especially in regards to medications. Those are mainly found in the GI tract, and we're not going to really talk about them here, but certainly the H1 receptors are the big things we're talking about. Now, we say H1 receptor antagonists, and truly they're not really antagonists. They're actually inverse agonists. You guys remember what an inverse agonist means?
Does it bind and cause the opposite reaction?
Exactly, yeah. So instead of an antagonist just sitting on a receptor and preventing the receptor from being activated by the endogenous ligand, it'll actually end up doing the opposite effect. So here, it'll do the opposite effect of what the histamine would be doing, so it can help to decrease some of that capillary dilation. It can help to decrease some of that leakiness and decrease some of the itching and whatnot. So, but just for ease of use sake, we'll just say H1 receptor antagonists here. So by giving these, they're going to be working to decrease the capillary dilation, decrease the itching we're having, and decreasing the swelling. There's lots of other physiologic actions that we're going to see, and we'll talk more about them when we get to the ENT section, and probably in a week or two. You'll see they're going to have a lot of effects up in the CNS. They're going to have lots of effects throughout the rest of the body. But here we're just going to focus on their ophthalmic actions. Some of the ones that you'll see being used in ophthalmic, and they have these dosage forms here. Keep in mind that these antihistamines tend to have some mast cell stabilizing properties themselves. So there are some benefit to giving these medications prior to this reaction happening. So if you know that you have seasonal allergies, or know you're going to be in an environment where you might be triggered, say if pet dander does it to you, and you know you're going into that environment, you may be able to use these beforehand to help with that mast cell stabilization to prevent them from degranulating in the first place, right? So that's some of the benefit potentially giving these before you're actually having an allergic reaction. The ones to note here include azelastine. Some of these you'll see will actually have ophthalmic forms, they'll have nasal forms. We'll kind of hit those as we get to them, but we have zelastine, imidazole, penistine, ketotifen. This one's of note because there's an OTC variety. So if you had a patient who maybe didn't have insurance, they could potentially go and purchase this over the counter as an alternative. And then also olopatadine or Patanol is going to be another common prescription agent. So typically these are going to be dosed 1 to 2 times a day, and typically if you can do it within onset, typically you'll see onset of action within a few minutes after it's being administered. Again, you don't have to wait for something like an oral product to be absorbed through the GI tract, through first pass metabolism, and go systemically. Since they're working directly at the site of action, the onset can be a little bit quicker. Typically when you start therapy, you want to wait for at least a week or two to really kind of determine how successful the therapy is going to be. If you try to do it too early, you may not have really seen the full effect of it, and so you may kind of prematurely discontinue use or try something different. As far as adverse effects go, they're really well tolerated for the most part. You might see some ocular irritation, maybe some headache, but it can cause some ocular dryness. And that actually does make some sense based on how a lot of these agents work. We'll see when we talk about antihistamines in a systemic context, they do have some anticholinergic activity. And so you guys know antimuscarinics or anticholinergics, what they do to the parasympathetic nervous system. You guys ever heard the mnemonic to know what anticholinergics do? What is all? Okay, so a good mnemonic, and this will come up later in the class. This is a good one to know for your parasympathetic nervous system. When you have an anticholinergic on board, it's going to be blind as a bat. So one of the things you're going to see with an anticholinergic is you're going to see mydriasis. You're going to be red as a beet, so you're going to see vasodilation, so it can cause some flushing. You will be hot as a hare. Even though hairs aren't really that hot as a match maybe. So you can see some hyperthermia. You'll have mad as a hatter, so you can see some CNS effects as well. And then you'll have dry as a bone. So that's the thing I want to focus on here. And whenever you're blocking the effects of the muscarinic receptors, you can have this decreasing of fluid secretion. So you see things like dry mouth, you see things like urinary retention, and here it can cause some ocular dryness. So this is some of those effects that you're seeing there due to the kind of the mixed activity of some of these antihistamines. Does that make sense? Again, so the anticholinergic effects, and we'll talk about this more when we get to like stuff like tox and things like that. But you'll be red as a beet. You'll be dry as a bone. You'll be mad as a hatter. You'll be hot as a match and blind as a bat. I think. Yeah, blind as a bat. There's the fifth one.
What was the blind as a bat for?
Yeah, it will cause mydriasis. We'll actually look at some agents that are anticholinergics that will be cycloplegic, so it'll actually cause mydriasis that are helpful for us to do some ophthalmic exams.
What was causing the blindness of that one?
The mydriasis that you're seeing. So again, when they have this mydriasis, it's not, you can't really accommodate to light anymore, so you see a lot of blurry vision happening from that. So that's where you're seeing some of the ocular dryness happening there. Again, because these are being applied locally and not systemically, you don't really see a ton of drug interactions that are happening. And again, these are typically going to be preferred over just your pure mast cell stabilizers, which we'll talk about next. Bless you. So the mast cell stabilizers, as you might imagine, they will help to inhibit mast cell degranulation. They will help to limit the release of things like histamine, tryptase, prostaglandins. So it's kind of nice because you're working kind of from an upstream mechanism. So prior to the histamine being released and causing all of its effects, you can kind of prevent that from occurring in the first place. What's one of the kind of the drawbacks of using a drug like this, though?
Does it reduce your immune?
No, you don't really see any immune dampening because of that, no. Well, what if you already have the mast cells degranulated? Are these going to work?
Too late.
They won't really work. You're kind of too late, right? So you have to use these prior to whatever the inciting event's going to be, or you have to be using it kind of consistently, say, taking it every single day in order to help prevent the degranulation from occurring. So the antihistamines, they can work after you're already having a reaction. These mast cell stabilizers are not going to work for that, right? So that's going to be a big distinction between these two. So again, you're going to be seeing decreased release from pro-inflammatory cells as well, so decreased activity from basophils, eosinophils, neutrophils, and all that. Yes?
Is this used before the reaction or after?
This would be used before the mast cell stabilizers. Yep.
Are all of these the H1 receptor antagonists?
No, now we're moving on talking about the mast cell stabilizers. So we said that the H1 antagonists do have some mast cell stabilizing properties, but they do not act primarily through that mechanism. Yep. So the agents that will fall into this category are going to include cromolyn, lidoxamide, and netocromel. Again, these are agents you're not going to see used quite as often as the ophthalmic antihistamines, just due to the fact that they lack that efficacy once a person's already having a reaction, right? Because
Prescription run over the counter?
yes, these are all prescription, at least that I can find. So again, you need to give it a couple of weeks before you really see full efficacy. So you at least give it between 5 to 14 days. And again, these are not going to be useful for acute symptoms. So you need to make sure that they're using this throughout the day prior to the inciting event to really know whether it's going to be efficacious or not. If the patient's only taking it when they're having a reaction, that's not really going to tell you whether or not the drug's really being effective because they're already having the reaction. But this may be preferable for patients who, say, have predictable allergies or predictable seasonal allergies in particular, who don't tolerate other therapies. So for whatever reason, say they got really bad dry eye with the antihistamines, they couldn't utilize those. This might be a good alternative for them if they know when they're going to have reactions. Again, as far as adverse reactions go, they're pretty well tolerated. You may see some ocular irritation, maybe some unpleasant taste. Where do you think the unpleasant taste comes from? Yeah, nasolacrimal drainage. When you have that, again, it can hit the back of the throat. You can end up getting some of that taste there, and then some headache. Hand up.
This is more of like a preventative.
Exactly. So this is So this is a preventative type therapy, and we'll talk about medications that work more as preventative versus for the acute reaction, especially when we get to things like asthma. We talk about that, or especially like allergic rhinitis. We'll talk about some meds in a couple weeks that work in a very similar manner, where they're more as controller medications versus being used for an acute situation. So this would be kind of considered like a controller type medication that prevents a reaction from occurring in the first place. Okay. So some other medications we can also use, they have combination medications where you can use a vasoconstrictor and also an antihistamine. So looking at this, we'll have some medications that are working purely as a vasoconstrictor. The way that these are going to be working are by activating post-junctional alpha adrenergic receptors on blood vessels. So when I do that, what is that going to do to the blood vessels? So activate alpha receptors on the blood vessels. They dilate or they constrict? They should constrict, right? Because I put vasoconstrictor on there, right? So they should constrict, and what's that going to do to the redness I see in the eye? It should lessen it, right? Because you're decreasing the amount of vasodilation that's there. You're decreasing the capillary leak that's happening. So hopefully you'll deal with some of that edema as well. Some of the agents we see here, we have tetrahydrozoline, or Opticlear is one of the OTC varieties. We have Nefazoline, Vasoclear. And then you also have this combination product that includes phenyramine, which is an antihistamine, and then you also have Nefazoline in addition to that. So, say for instance, if you had someone who was, having say red eye due to something other than a typical type of say allergic reaction, they may be able to get away with just using something like a pure vasoconstrictor versus using the antihistamine using something with an antihistamine activity, right? Now, these are going to be better used for short-term courses of therapy, and the reason for that is anytime you're using vasoconstrictors, we talked about receptor downregulation, upregulation. So if I'm constantly constricting these vessels on these alpha receptors, what do you think those receptors are going to do in response to that? They're going to upregulate or downregulate? They should be. What should they be doing? They should be downregulating, right? So they should be downregulating because I'm constantly activating. If I'm blocking the receptors, they should upregulate, right? But here I'm actually having things that are activating those alpha receptors, so there should be some downregulation. So say I'm activating these alpha receptors, I have downregulation. Now what happens if I take the drug away? I have fewer alpha receptors, and does that make it more difficult or more easy to keep that same amount of vasoconstriction happening? It's more difficult because there are fewer receptors to activate. So what ends up happening is you get this rebound effect, this rebound hyperemia that can happen after, especially if you're using it for chronic period of time. So several weeks, take it away, and all of a sudden you get this really bad rebound hyperemia. You can see a lot of swelling, a lot of red eye that can come back from that. You'll see the same thing happen when we talk about nasal decongestants that work via vasoconstriction. You have the same thing happening there, where you really recommend against using it for chronic periods of time, just due to the fact you have that rebound effect. Right? We'll see the same thing happen as well when we talk about antihypertensives that are working through a similar mechanism. Now, if you are using these medications, say, especially with these being over the counter, you run the risk of patients who are kind of self-diagnosing, and if they're using it for, say, more than 72 hours and they're not getting any better, that's when they really need to be advised to come for follow-up, because there could be something else going on. It could be a bacterial etiology, or it could be something else happening that really needs to be addressed, and maybe some different type of medication being used or something else entirely, right? So again, this is kind of one of the dangerous things with people kind of self-medicating themselves, is they could be kind of overlooking something more serious. So one thing I want to note about these agents is that they are considered to be Imidazoline derivatives, these vasoconstrictors. That's kind of one of the classifications they could fall in. And so one of the things I wanted to note here is that these medications, while locally, when applied to the eye, they're going to be working on these postsynaptic alpha-1 receptors that cause vasoconstriction. Systemically, they can also be affecting alpha-2 receptors. Does anyone know what alpha-2 receptors do up in the brain? So alpha-2 receptors actually work as autoreceptors, which basically means that when you activate the alpha-2 receptors, they decrease the amount of catecholamines that are being released by the central nervous system, right? So by activating alpha-2 receptors up in the brain, I'm decreasing the amount of epinephrine being released, dopamine, norepinephrine, all those things are being inhibited. And what does that do to my blood pressure systemically? Should decrease it, right? Because I have less catecholamines being released. The reason why I mention this is because this is going to be really dangerous if kids get into these products. So if someone were to accidentally ingest some of this, say, some Visine that has one of these vasoconstrictors in it, they may initially see some vasoconstrictive effects from the alpha-1 receptor activity, but eventually they're going to have this kind of overwhelming effect on the alpha-2 receptors. You're going to see a lot of decreased amount of catecholamines being released, and they get very, very hypotensive, right? So that can be a really big problem with children, childhood poisoning, is with them accidentally getting into some of these products. And again, they're over the counter, so they're in homes, they're available, kids can get into it, and it only takes a very little bit in order to cause really significant systemic effects, right? So normally you don't see this in adults so much, but we have had cases where kids get pretty significant poisoning from this. That makes sense?
They consume it?
Yeah, so they'll ingest it. So they'll just be like, oh, this, parents are doing this. This looks good, and then they'll just swallow it, right? So I've had some pretty sick kids from ingesting some of this stuff. You'll see some antihypertensives actually work through the same mechanism. So if you ever heard of a drug called clonidine, it's going to do the same thing. We'll talk about some glaucoma meds in just a little bit that actually work through this similar mechanism as well, but they work locally within the eye to cause to alter your intraocular pressure. But we'll talk about that in a little bit. Okay. The next class of medications that we can talk about is going to be the NSAIDs, or the non-steroidal anti-inflammatory drugs. And so the way that these medications are going to work is that they're going to block the activity of cyclooxygenase. Otherwise, it'll be shortened to COX. Now, what inhibiting this does, what COX normally is going to be doing, is it will help to convert the arachidonic acid that is liberated from the phospholipids within a cellular membrane. Arachidonic acid will go through this pathway where they can eventually be used for kind of pro-inflammatory purposes. So it'll produce things like your prostaglandins, it'll produce things like leukotrienes and all these different things through this whole pathway. So what the NSAIDs are doing is they're actually blocking the activity of cyclooxygenase and preventing the arachidonic acid from being converted over to anything in the first place, right? So that's how they're going to be working. Now, there are 3 different COX isoenzymes that we'll talk about throughout the course, but the 2 that I want to really focus on here are going to be your COX-1 and COX-2. COX-1 is what we consider to be a constitutive cyclooxygenase enzyme. So what does constitutive mean?
Does it live there?
It's there all the time, right? So basically, your body's always producing, COX-1 activity is always happening. You're always needing these prostaglandins, and that makes sense because if you look at what the activity does here, you see that they do things like they help protect the gastric mucosa, they help with hemostasis. On the other hand, though, you have your inducible COX-2 inhibitor, or your inducible COX-2, and that's going to be things that are triggered, basically. So say I sprain my ankle and I have some local inflammation, that's going to trigger COX-2 because that's an inducible cyclooxygenase. And that's where I'm going to have things that mediate pain, mediate inflammation, and fever as well. And so what I can do by applying these non-steroidal anti-inflammatory drugs in the eyes is I can prevent these pro-inflammatory mediators from being made in the first place and decrease inflammation within the eye. Can anyone think of like some situations where I might want to do this? Maybe we're like inducing a lot of inflammation in the eye on purpose? Or is that kind of a secondary or kind of a side effect? Usually like with surgery. So we'll see surgery is going to be a big area where the eye is very inflamed, and we can utilize some of these non-steroidal anti-inflammatory drugs to help limit some of that in order to help with the healing process and make it a little bit more comfortable for the patient. Can anyone think of any non-steroidal anti-inflammatory drugs that they know of? Ibuprofen. Naproxen's a good one. Aspirin does have will work very similar. We'll kind of talk about it separately, but yeah, it definitely falls in this category. Good. So those are some pretty common ones. The ones we'll talk about for ophthalmic use, you'll see we have bromfenac, diclofenac. Some of these you will see will be used via other routes as well. So like diclofenac is commonly used either as a topical gel. You may see it being used orally. We have ketorolac. Some people just say ketorolac, but it doesn't really matter how you say it. That one is frequently used via the IV route for pretty significant pain management. But all these can be used via the ophthalmic route. These are typically going to be relegated to being used for postoperative inflammation, for pain, and in kind of refractory allergic conjunctivitis. You don't really see it being used all that too often. This would be for someone who's kind of failed the other therapies, like the antihistamines aren't working for them, mast cell stabilizers aren't working. This might be an option for them if they kind of fail other things. Some of the problems that we can see with these medications is it can lead to increased lacrimation. You can see induction of keratitis that can occur, can lead to intraocular pressure increases, and also ocular irritation. So really these are going to be more relegated to more specialty use more than just kind of general prescribing. Other drugs that we can use to decrease the amount of inflammation that's occurring within the eye is using glucocorticoids. So again, these are going to be our steroids that we're talking about. These really are going to be suppressing more of a late phase allergic reaction. So what they're going to be doing is really working more on the nuclear level to help alter gene transcription to help decrease a lot of these mediators from ever being made in the first place. Now, if you actually look at the onset to action for these different anti-inflammatory type drugs, you'll see that things like antihistamines work very quickly because, again, if histamine's already being released, you can just go and block those receptors and it's working immediately. Things like glucocorticoids that are working on the actual gene transcription and protein regulation, these are going to take longer to work. So glucocorticoids tend to have a much slower onset of action than a lot of these other medications might. These are also going to be useful in the surgery realm because they can actually inhibit fibrin and collagen deposition, so it actually will decrease scar formation from happening as well. So that's one of the other benefits you can see in a post-surgical setting. So the main uses that you're going to see some of these glucocorticoids being used for are going to include severe ocular allergy. So again, if they fail at absolutely everything else, you can potentially use a glucocorticoid. They have an anterior uveitis, any kind of external eye inflammatory disease, and then also inflammation following ocular surgery. Right? So if you've done surgery and they're really inflamed after the fact, you can potentially use glucocorticoids to help kind of tamp that down a little bit. Now you can apply some of these intraocularly. We'll see one of the medications that can actually do that, but most of them will end up being applied topically because, again, they do have pretty good absorption through the cornea and get to their site of action. So again, just looking at glucocorticoid actions, we'll talk a lot about glucocorticoids because you can use them for many different types of disease states, a lot of autoimmune disease states, a lot of inflammatory disease states. But just to look to see what they do, they kind of work to decrease the immune reaction across the board. So working on every type of immune cell, working to decrease all the different prostaglandins and different inflammatory cytokines that can be made. They decrease all of these. So is there any problems that you can imagine from using a glucocorticoid like this? If I'm depressing my immune system, what's the potential that I could see there? Infection, absolutely. So one of the big things you're going to be worried about anytime you're giving, especially systemic corticosteroids for long periods of time or with big doses, is infection is going to be a big risk you're going to run into. And the same thing can happen here, even locally, because I'm having a local depression of the immune system, which can lead to possible secondary infection. Especially if they are already immunocompromised, may be more at risk for things like fungal infections or viral infections, not just bacterial. So again, these are generally going to be used for more refractory symptoms. Some of the issues that we can see from utilizing ocular glucocorticoids include potential for cataract formation. It's obviously a pretty bad thing. We don't want to do anything to worsen the patient's vision, but you normally would see this with more chronic, more high-dose use. Potentially, you can see increases in intraocular pressure. So if your patient already had glaucoma, this could actually worsen that. Due to the depressed immune system, you can end up seeing potential for infections. And then also you worry about risk for delayed wound healing. So we said that it was actually good for decreasing some of that scar formation, but in the long run it can actually decrease wound healing and have wounds stick around for a little bit longer. And then we also run the risk for corneal ulcers as well. So typically these are going to be relegated to more refractory symptoms, and you're really going to limit it to more kind of pulse type therapy, where you're only going to give it for a short period of time, so say less than 2 weeks. Right. So whenever we say like pulse dose steroids, those are typically going to be short courses of steroids, not something you're going to take every single day from here on out, right? Some of the agents that you'll see, some of these you'll see being used systemically, including things like dexamethasone or prednisolone. You'll definitely be seeing these used via the oral route or via the parenteral route. You also have some of these soft steroids, as they call them. These are the ones I have starred here. This includes the fluoromethalone, loteprednol, remexolone. Those are all considered to be soft steroids because they have lower risk for increasing intraocular pressure. So if you had a patient with glaucoma, these might be a better option to give them because it runs less of a risk of increasing that intraocular pressure that may or may not already be controlled, right? I put the triamcinolone here as well because this is an actual formulation that's designed for intravitreal injection, so it may be good during ocular surgery to kind of decrease in that post-operative inflammation by delivering it directly to the site of action instead of allowing for that transcorneal absorption. Okay, so moving on. Oh, that was a really good picture of Ben Stein. So anyway, so the next thing we'll talk about is going to be therapy for dry eyes. We talked about a lot of medications that could potentially cause some irritation, maybe some dry eyes. There's lots of different conditions and different things that can cause that may be affecting that precorneal tear film. Again, that's a hard thing to say. You can have chemical burns, you can have corneal dystrophies. All these different things can potentially alter the ocular surface and may actually affect the tear composition as well. So in my line of work, being in toxicology, you would end up seeing issues where patients would have gas exposures to different chemical irritants. So has anyone ever mixed bleach with an acid before? No one's ever done it in the bathroom on accident? Yeah, ammonium bleach. Anything like that? Has anyone ever opened up like a thing of pool cleaner, the chemical, or the chlorine tablets? You got a big whiff of that. So you can actually see chemical burns from some of that because those are irritant gases that can be off gas from those. So anyway, again, you can have other systemic conditions maybe affecting or causing dry eyes. So things like autoimmune conditions like rheumatoid arthritis and other things like vitamin A deficiency and also Stevens-Johnson syndrome. Have you guys heard of Stevens-Johnson syndrome before? So it's typically a drug interaction you'll end up seeing, or it's induced by certain medications. We'll come across it pretty frequently, well, some frequency. It's important to note when drugs that can cause Stevens-Johnson because it can be so severe. Basically, it's in this autoimmune induced effect where you see a lot of very significant rash, and you also see a lot of skin sloughing. It can definitely be fatal if not caught early and treated pretty aggressively. So anytime you see Stevens-Johnson syndrome, it's a good thing to note and to make a mark of it in your books. But certainly dry eyes can be caused by Stevens-Johnson syndrome as well.
Is there a certain drug that causes that, or is there like a...
We'll hit them as we go along, but yeah, there's lots of drugs that will cause that. So things like Bactrim is going to be a big one. A lot of anti-epileptics you'll see can cause it as well, but we'll talk about them as we encounter them. So when treating the dry eyes, the important thing is to first treat the disease. So if we can affect the disease state and try to deal with that first and foremost, that'll oftentimes fix the issue with the eyes. But in the meantime, you may be able to do some things like physical interventions. We talked about this before, where you could actually do things like punctal plugs. You could do potential surgical occlusion of the lacrimal drainage. But in the other ways we can do it with medications would be with tear substitutes. So these are typically products, either hypo or isotonic solutions. They'll contain things like electrolytes, and more importantly, they'll include things like surfactants and thickeners. And what this will do is actually to increase the time that it's in the cul-de-sac and increase its contact time with the eye and allow it to last for a little bit or much longer than we see like normal tears. So this is where you see things like balanced salt solution can be used for the eyes. You can see things like carboxymethylcellulose, hydroxypropylcellulose, polyvinyl alcohol. That one's frequently known as artificial tears. All these different products can be used for tear replacements for dealing with patients with more chronic dry eye issues. Okay, and then one other medication we can potentially use for chronic dry eye would be cyclosporin or Restasis. Does anyone know where else you might see cyclosporin being used? Yeah, I heard transplant, absolutely. Does anyone know what that does?
Must reduce immune.
Yes, it reduces the immune system, so it helps to prevent graft versus host disease when you have transplant of solid organs. Here, you're going to see it actually being used as an anti-inflammatory by inhibiting the production of interleukin-2. By doing that, you're going to have a lot less signaling to your T cells, and so less activation of it in the eye. And so these would be applied locally, and what this is going to do is it actually has been shown to decrease inflammatory markers within the lacrimal gland. It increases tear production and will increase vision and comfort for your patients. So this is going to be more for patients who have chronic dry eye, especially if it's associated with an inflammatory condition. So if they have like keratoconjunctivitis, that might be a good indication for it. Some of the big adverse effects you're going to see with this more frequently include ocular burning, which sounds like a bad thing, but I guess if your eyes are already burning from being so dry, this might be a good trade-off. If you have a foreign body sensation and blurred vision can happen somewhat frequently. And there's no real drug interactions here. You don't necessarily see a lot of increased risk for infection like you would see with the glucocorticoid. Due to the fact that it's a little bit more targeted and just really affecting that T cell signaling rather than dampening the entire immune cascade. So any questions on that? All right. So moving forward, we will begin talking about our glaucoma medications. You guys covered anything with glaucoma yet? Okay, so you at least get a little bit of introduction here. We'll talk all about the medications used for it. So glaucoma is going to be characterized basically, if you kind of distill it down, is increased intraocular pressure. So it's basically like eye hypertension. What can happen when you have this elevated intraocular pressure for prolonged periods of time is you can end up seeing this optic neuropathy. You'll have loss of retinal ganglion cell axons, and then you'll eventually have decreased visual field loss and irreversible blindness that can occur. So obviously we want to prevent that, and so we have lots of medications that can help us with that. Now there's two different varieties of glaucoma. There's mainly the open and closed angle glaucoma, and you'll see that the medications that we have are really going to be focusing on open angle glaucoma. The targets that we're going to be focusing on here is that, what's causing the pressure within the eye? Yeah, the aqueous humor that's in the eye, right? So two ways we can actually deal with decreasing that pressure would be one, to decrease the amount of aqueous humor that's actually produced, right? And the other way you can do is to increase the outflow. So either decrease production or increase the outflow are going to be the two main ways we're going to deal with this aqueous humor and decrease that intraocular pressure, right? There's nothing funny about too much aqueous humor. You don't have to laugh at that. Yes, thank you. Anywho, so normal ocular pressure should be anywhere between 10 to 21 millimeters of mercury, and this ocular hypertension would be defined as pressures higher than this, higher than normal, that is in the absence of optic nerve damage or visual field loss. So before you really have any issues with it, you're really just considered to have ocular hypertension. This open angle glaucoma is going to be basically what we're talking mostly about in regards to medications, because this is the one that's either caused by increased production of the humor, or it's going to be decreased drainage out of the eye, preventing, causing that pressure to rise. And again, they may have optic nerve damage or decreased visual field, but it may not have occurred just yet. So it could be, this is kind of a prolonged, kind of long game kind of thing, and hopefully we can get to treating it, early on to help prevent any of that damage from occurring. The angle closure glaucoma or closed angle glaucoma, that's going to be more just due to a physical blockage of the drainage canal, and they may have total normal optic nerve, but usually they're going to have some kind of acute pain. So this is more of kind of a surgical issue that really is a medication issue. So again, we're focusing on open angle glaucoma. Just to show a picture between the two, you can see here on the left side on the open angle glaucoma, you can see that the flow is not really being impeded so much. It's able to flow past the lens just fine, but the issue is either it's not really exiting the eye, or it's just too much is being produced in the first place. On the other hand, you can see where the blockage kind of occurs with the closed angle glaucoma, and just that acute increase in pressure is really what's causing a lot of that pain there. And again, no drug is really going to be able to really help with that issue there. So again, the things we're going to be focusing on are going to be to help prevent that progressive optic nerve damage, and then hopefully have minimum risk of side effects from either topical or systemic therapy that we'll see. And so this is where we're going to get into more medications that can be potentially causing systemic side effects, and so those are the things we want to look at preventing for your patients. Because again, kind of what age of patients are we thinking about when you think glaucoma patients? Older patients, right? And what do they often have? Yeah, hypertension, diabetes, all kinds of other disease states, CHF. They often have a lot of other disease states that are happening that can be interacting with some of the medications we'll be talking about here. Okay, so if you're looking at drugs that will increase aqueous outflow, the ones that fall in this category are going to be our prostaglandins. And again, these are typically going to be our first-line agents. Let's say it's some kind of contraindication. You'll see that our alpha adrenergic agonist fall in this category as well. Again, we've already seen some alpha adrenergic agonists. We talked about some of the ocular vasoconstrictors, but these will be different agents. And we also have cholinergic agonists. So again, those will be working on the muscarinic receptors. In order to decrease the aqueous production, we have other drugs that can do that as well. Again, you see that the alpha adrenergic agonists fall into this category. So again, they kind of perform double duty. You'll have beta blockers, and then you'll also have carbonic anhydrase inhibitors. We'll talk more about these in detail, but it's good to know which drug is going to be performing which action, and this is going to be important when you talk about things like combination drugs. Like, how can I work synergistically by adding drugs that are going to be working through different mechanisms, right? So it may make sense to do a prostaglandin plus, say, a carbonic anhydrase inhibitor, or to do an alpha adrenergic agonist plus a beta blocker, right? So again, using that kind of rational approach to make sure we're using the right mechanisms to help have that synergy there. Okay, so looking at prostaglandins as our first line agents, these are going to be working as analogs of PGF2 alpha. And what they're going to be doing is binding to prostaglandin receptors within the eye, and they're going to help to lower the intraocular pressure by increasing aqueous outflow. Now, how this actually works, no one really knows. Who knows? But they think it may be due to altered ciliary muscle contraction and changes in that trabecular meshwork of cells. So how the aqueous humor is actually leaving is thought to be due to changes to the muscle and then also the trabecular meshwork. But again, the actual what's happening there, no one's really kind of fully elucidated yet. And you'll hear that a lot. There'll be some drugs that we're just like, we don't know how it works. It just works, right? And you just have to be okay with that. It's one of the things you have to come to terms with medications. Because as students like everything to be black and white, but sometimes we have no idea. So anywho, the agents that will fall. Oh yes.
Sorry, when that happens, is that because there may have been like the drug was initially intended for something else, and that just happened to be like a random effect of it that they realized, oh, this works better as this drug?
So there are.
Right?
That's a great question, because there are actually some drugs that have come about through that mechanism, right? So if you take, for instance, minoxidil or Rogaine, that originally was intended to be an antihypertensive. It works as a vasodilator. When you gave it, it actually caused really bad hypotension for patients. But the thing they noticed was increased hair growth. So like, let's just put this on topically, and all of a sudden now we have a brand new product, right? So some drugs are found to do that. We'll actually talk about another one. Actually, one of these drugs can be used for a secondary purpose. But no, in this case, they knew the prostaglandins worked to increase that aqueous outflow, but they weren't able to actually give the prostaglandins themselves because it just wasn't really stable. Kind of had some bad side effects of its own. But by giving these kind of prodrugs that are analogs of prostaglandin, they get converted over to the prostaglandin itself. They see that it has very similar actions. So that's a great question. Some of you guys probably already noticed the one that I'm talking about that has a secondary activity, but we'll talk about that in a second. So the agents that are used here as prostaglandin analogs will be our latanoprost, our travoprost, our bimatoprost, and our tafloprost. Big things you're going to be seeing here as far as adverse reactions go include, you can see some conjunctival hyperemia, some ocular irritation, and then the big thing here is going to be this changes in eyelash length and iris color. So does anyone know what the positive thing here is? Eyelash length, absolutely. And the nice thing about these medications, because they're applied locally, you don't really see a ton of systemic side effects from their administration. Even if you did have some absorption from the nasolacrimal drainage, you really don't see anything systemically. So it's basically these medications are first line because they're effective, but they're also very well tolerated for the most part. So if you can look here on this picture on the bottom left, you can see here that the iris has turned very brown. So this might have been a patient who only had ocular hypertension in one eye. It was receiving that. You can see the other one was actually green. Now this is actually can be somewhat reversible, but in a lot of cases is not reversible whatsoever, right? So that's going to be one of the negative side effects. So if you have pretty blue eyes and you take this stuff, you run the risk of having brown eyes at the end of it. The thing we were talking about, the secondary activity that some people do like is this eyelash lengthening. And so Latisse is a brand name for bimatoprost that is marketed directly for increasing eyelash length, right? So it's nice for someone who already has brown eyes. They're like, well, I want longer eyelashes. I'm just going to use this stuff, and you're good to go, right? So it's kind of a cosmetic use for a product that is originally used for glaucoma. And again, it's very well tolerated for the most part. So really, you don't have to worry about a lot of systemic side effects. So using for the cosmetic purpose, really isn't going to be causing any negative effects to the patient besides the change in the iris color.
Can you use it in both eyes so that they at least look the same?
You could, yeah. But this might have been
change in the same, or no? Well, sometimes one eye stays.
I don't know that I've ever heard of, if someone's getting the same dose in both eyes, if one would change more than the other. I'm not really sure. That's a good question to ask like an ophthalmologist. Maybe they've seen something like that. But yeah, that's a good question. Okay. The other thing to note is that the nice thing about prostaglandin analogs is that they can only they should be dosed once daily. So it's really good for compliance with your patients. Instead of having to give something several times a day, just giving it once daily is nice. Now, don't exceed this, because what they actually end up seeing is if you apply it more than once daily, you can actually end up seeing this inhibition of the lowering effects and actually end up increasing intraocular pressure for whatever reason. We don't really know the mechanism, but they actually end up seeing some inhibition of that effect. So just dose it once daily and you're done. Moving on, we next have our beta blocking agents, and these are going to be working specifically by blocking beta adrenergic receptors, right? So again, we go back to our sympathetic pharmacology. By blocking beta receptors in the ciliary body epithelium, this leads to less catecholamine activation, right? So things like epinephrine, norepinephrine are less able to activate those beta receptors because they're being blocked. And then you see decrease in cyclic AMP. You guys remember what that is? Secondary messenger. Remember all those from pharmacodynamics? They do make a return. So you see decreased cyclic AMP, and that's going to lead to less aqueous humor production, right? So that secondary messenger is not being activated, so it cannot lead to that response of having that aqueous humor being produced. So beta blockers blocking the adrenergic beta receptors. So looking at this, we'll talk about selectivity of medications. And so you'll note here, I have another slide on this, but basically you have one drug, betaxolol, which is going to be a beta-1 selective medication, right? So it's only going to be really affecting beta-1 receptors. You then also have your non-selective beta blockers, which will be affecting both beta-1 and beta-2. And so these will include cardiolol, timolol, and levobunolol. Timolol is actually another one that can be seen used for oral use as well, so you'll somewhat frequently see that. So the non-selective agents are actually going to be a little bit more efficacious than your selective agents because the eye happens to have a higher propensity to, or higher density of beta-2 receptors than beta-1 receptors. But there are some inherent problems with using unselective beta blockers. And so some of the things you'll see, and I'll show you the reason why in just a second, is that you can see worsening of heart failure, you can see bradycardia, you can see heart block as an extension of that, and then also increased airway resistance in patients who have asthma. So why is that? So basically, if you look at the dispersal of beta receptors within the body, if you look at beta-1 receptors, those are primarily going to be found within the heart, right? So that's why I use beta blockers for things like tachyarrhythmias. We can use it for things like anxiety, because again, if your heart's racing, you may be more nervous feeling. Beta-2 receptors, on the other hand, are really found more on the vasculature. They help with vasodilation, and they also are all found in the lungs. And so if I activate a beta-2 receptor in the lungs, what does that do? Bronchodilation, right? That's why we use things like albuterol as a beta-2 agonist that causes bronchodilation. So if I were to block beta-2 receptors, what is that going to do for me? Right, so if I were to have some kind of event that was leading to a bronchoconstriction and I try to give my albuterol as a beta-2 agonist, what's going to happen to those receptors? They're already blocked. They can't really be activated. So you run the risk of having a patient having decreased efficacy from their asthma medications due to these beta-2 receptors being blocked. So that's kind of the benefit of using a beta-1 selective agent, is that you prevent those beta-2 receptors from being hit. So my caveat, though, and I'll mention this again when we talk about other selective agents, is that drug selectivity for receptors is all relative, right? You can say a drug is beta-1 selective, but if I increase the dose enough, it's going to lose selectivity eventually, right? So at some point, those beta-1 receptors will be all activated, but the drug can still affect beta-2 receptors. It just requires a higher dose. So again, selectivity is all relative, and it's all relative to the dose that you're administering. So that's why we see, especially with like major overdoses of things like beta blockers, even if it's a selective one, you can still see beta-1 and beta-2 effects really happening there, because the drug will end up losing selectivity because of that. That make sense? All right. So again, the non-selective beta blockers are going to be better for glaucoma, more efficacious because of the fact that the eye has more beta-2 receptors, but the beta-1 selective blocker might be better for patients who have things like asthma, because it's going to help to prevent that bronchoconstriction. Now, will the non-selective ones still cause things like bradycardia? Absolutely, right? Because the beta-1 receptors are the one that are really primarily on the heart. So if I'm having even a beta-1 selective blocker, that's still going to block the ones on the heart, right? So you still run the risk of having bradycardia and heart block that you can see from that. And again, that goes back to worsening CHF and whatnot if you're decreasing their, their ejection fraction. So again, these are big ones you have to worry about, having that systemic absorption from nasolacrimal drainage. So this is another good one to make sure they're really applying it correctly and making sure they're blocking off those ducts for that 2 to 3 minutes to prevent some of that absorption from occurring. Because you can certainly have patients who are having systemic side effects from these medications being applied ophthalmically. Moving on, we then have our alpha adrenergic agonists, and so these are going to be primarily working by activating the working presynaptically and postsynaptically. So you have the alpha-2 agonists are working presynaptically, and like we said before when we talked about the Imidazoline derivatives, these are working to decrease catecholamine outflow, right? So they're decreasing the amount of norepinephrine being released and epinephrine, and similar to how the beta blockers are blocking the receptors, preventing those catecholamines from activating them, these guys are decreasing the amount of being released in the first place. So they're kind of working through a similar mechanism to decrease the amount of the actual aqueous production, right? And then postsynaptically as well, the alpha-2 activation is going to help decrease aqueous production as well. So kind of through two mechanisms, increasing outflow and decreasing production, right? So both working presynaptically and postsynaptically. So that's why it kind of falls into both categories there. The two medications that fall in this category are going to include aproclonidine and also brimonidine. Does anyone know what drug this might be related to, an antihypertensive? Has anyone ever heard of it? So anyone heard of the drug clonidine? So you're here clonidine, this actually falls into the same category. So clonidine is a drug that's given systemically for hypertension most often. Sometimes you'll see it used for things like ADHD as well. But clonidine is going to be in the same category. So we'll talk about that when we talk about antihypertensives. But for right now, the important thing to note here is that these agents, if they get into the central nervous system, they can cause systemic effects. And so the nice thing about these drugs is that they are typically going to be highly ionized at physiologic pH, which is good because it actually prevents them from crossing that blood-brain barrier, right? So we said the more highly ionized they are, the less likely they are to cross biological membranes, and that includes the blood-brain barrier. Some of the adverse effects you can see from these alpha agonists include ocular irritation. You can end up seeing some hyperemia, especially as a rebound effect if you were to remove the medication, very similar to the effects we talked about with the other vasoconstrictors. Also, you can have some allergic conjunctivitis to these medications as well. You typically see less of this with brimonidine, so that one typically gets used a little bit more frequently. One thing to note here as well is very similar to what we were talking about with the accidental poisoning with those ophthalmic vasoconstrictors, is that these agents are contraindicated in children less than 2 years of age. Because the alpha-2 effects by decreasing catecholamine release, you can also see depression of the CNS. So you end up seeing CNS depression, increased lethargy, and apnea happening as well. So very young patients were given this, and they can more likely see systemic effects. So that's a good contraindication to know. Yes?
Sorry, which drug was that for?
That's for both of them. It's a class effect for those.
Can you repeat what you said? Sorry.
Yep. So because kids typically have kind of less fully developed blood-brain barriers, they're not able to keep these drugs out as well, and so you're more likely to see these systemic CNS type of effects from these drugs in very young patients. That's why it's contraindicated in those less than 2, because you have increased risk of CNS depression and apnea as well, right? Because if I decrease the amount of catecholamines are being released from the central nervous system, again, you're going to think about people getting more lethargic. You can see ataxia and all that stuff, and then eventually apnea if they're CNS depressed enough. But luckily especially with adults with fully formed blood-brain barriers, most of the systemic effects are limited just due to the fact that the ionization keeps them from crossing the blood-brain barrier in the first case. It's just that very young children are just more susceptible to it. So moving on, the next class of meds we'll talk about are going to be our carbonic and anhydrase inhibitors. These ones are used even a little less frequently than you would see with like our beta blockers or alpha agonists. They are some of the earlier anti-glaucoma meds that we came up with. So the mechanism that they're going to be working by, as you might imagine, is to block the actions of carbonic anhydrase, which is an enzyme responsible for converting CO2 and water into bicarbonate, basically. So I'll show you a diagram. It's very confusing in just a second. I'll try to make it clear why this works to decrease the amount of the actual amount of aqueous humor that's being produced. So again, we have we're going to end up having less fluid being transported, and you're going to decrease the intraocular pressure through this mechanism. The two drugs we're going to have in this category include dorzolamide and brinzolamide. There was another agent called acetazolamide that also works by this mechanism, but we'll talk about that when we get to diuretics. But that's another carbonic anhydrase inhibitor you might run into in your days. Some of the adverse effects with this, making it a little less tolerable to some patients, include a bitter taste you may experience, and also some burning and stinging after administration, and then also some chance for allergic conjunctivitis. So, looking at this graph, or this picture here, you can easily tell why this decreases aqueous humor production, right? It's not obvious? Come on. Okay, so this is really confusing to me too when I first saw it. I was like, I think this is right, but yeah, no, it's right. So the thing you have to remember is that where the solutes go, where things like sodium and chloride go, what follows it? Water wants to follow it, right? So basically what you're seeing here is if you're looking at the top of the picture here, you have your CO2 in your water, and you see that Ca, that's carbonic anhydrase, that's working to convert that over to bicarbonate. And so you can see on either side of these epithelial cells that co-transporter with the bicarbonate being shuttled out, and that's helping to draw in chloride and sodium, right? So by drawing in more chloride and sodium, you're going to be having more flow, and you can kind of see down here at the bottom kind of that natural flow that's happening, which direction it's going in. That's the natural direction of production of the aqueous humor. So you're driving these transporters to end up drawing in more solutes to make more production of aqueous humor. So more water's flowing. So by blocking that, by blocking the effects of carbonic anhydrase, you have less of it, bicarbonate ions being produced, and you kind of shut this process down to some degree, and so less fluid is actually moving across and being put into the intraocular space. Kind of make sense? Don't get too drugged down in this. Just know that the mechanism is that you're blocking the activity of that enzyme, carbonic anhydrase. We'll see this come up being important for diuretic actions in the kidneys, and you'll also see carbonic anhydrase inhibitors being used for things like altitude sickness and things like that, which we'll talk about later.
Quick question on
Yes.
the slide.
Mhm.
So the right side of the box is like where it says the posterior chamber.
Yep.
So that's where the pressure's going.
Exactly, that's where the pressure is being built up at. Absolutely. Okay, so the next class of medications we'll talk about are going to be the cholinergic agonists. So as we talked about with our anticholinergic activity, if you have an antimuscarinic on board blocking those receptors, we said that you were blind as a bat, right? Which means we had mydriasis. So instead, if I had something that was activating those muscarinic receptors, you'd expect to see meiosis occur. So again, as the picture looks here, you see this meiosis happening. Some of the agents that we'll see being used include acetylcholine itself. You can actually apply acetylcholine directly, most often used for surgical settings. And then some other ones you'll see include carbachol and pilocarpine. Now these are not used very frequently because of the kind of the intolerability of the side effects we're going to be seeing here. Also because you have to apply it very frequently throughout the day. Like, prostaglandins are nice. You should give them once a day. These might be given several times throughout the day. The problem with this is that, can you imagine how easy it would be to really see in your day-to-day life with your pupils being that small? Kind of difficult, right? So because you can't really accommodate to light very well, it makes you have this myopia. It's very difficult to see unless you have other visual disturbances, and it just makes it really intolerable to patients. So you don't really see it used that often outside of the more surgical type setting. Moving on. The other big thing you can use is combination product, which are nice because they limit the number of drops you're having to administer. So some of the common ones that are available include things like brimonidine and timolol. Again, you see different mechanisms being combined to have synergistic effects. Brinzolamide and brimonidine, dorzolamide and timolol, using different mechanisms in order to help decrease that intraocular pressure. Again, fewer drops to administer, better chances for compliance because your patients only have to administer one drug versus two, right? So who should you treat in regards to glaucoma therapy? In a lot of cases, if you don't necessarily have a lot of risk factors, you can generally monitor the intraocular pressure for a period of time until you start to see some glaucomatous changes occur. But those that do have risk factors, say positive family history or really high risk for having visual field changes and things like that, should be treated. And so in general, you're going to start with the prostaglandin analog. If they can't tolerate that for whatever reasons, they have an allergy or something, beta blockers would be kind of your second line agent to go to. Again, you can potentially start therapy in just one eye by itself to determine efficacy. So you can actually just do kind of a pre and post at the same time by giving the drug in one eye and look at the change in intraocular pressure and be able to compare to the two at the same time. And generally, the goal is to decrease the intraocular pressure right around 20 to 30% in order to get that controlled and help to decrease some of those changes from occurring to the optic nerve over time. So any questions on glaucoma? Okay, some other kind of miscellaneous medications we'll talk about in the ophthalmic field include ocular anesthetics. So these are going to be some of your bread and butter stuff. Anyone that goes to work in ED or primary care, they're doing visual exams, especially if people have like injuries and things like that to the eye. You'll be using these quite frequently. So the mechanism that these anesthetics are going to work by, and you'll see this pop up when we talk about anesthetics in general, is that they inhibit sodium influx into neurons and they prevent propagation of action potentials. So normally if you're looking at a neuron, how the way the signal transduction happens is that you have the myelin sheath and you have those kind of gaps in the myelin. The signal is jumping as you go up the nerve. By blocking sodium channel influx, you block that propagation of the action potential. And by blocking that nerve impulse, if your brain's not feeling it, you're not feeling it, right? So that's essentially how that's working here. The two agents that we're using here include tetracaine and proparacaine. So those are your main ophthalmic anesthetics you're going to see used. Again, you can use it for prior to tonometry, for foreign body removal, and then also for superficial corneal surgery. So this is used very, very frequently, especially prior to doing a fluorescein stain using a Woods lamp to look for any kind of look for injury. Only adverse effects you may see, pretty rare, but you can see some hypersensitivity or burning sensation. But again, once the eye's numb, then you're not really going to be feeling much of that burning in the first place. Keep in mind that after administration, the eyes are going to be numb for around 10 to 20 minutes or so. So that also means the patient's not really going to have a blink reflex, right? They're not going to be able to tell when their eyes are really starting to get dried out. So the big thing I make note of here is that you never want to write prescription for this. Like you can write orders for it, like in the clinic or wherever you happen to be working, but you never want to send a patient home with a prescription for these anesthetics. And anyone think of the reason why? Well, if they're self-medicating, they're using this to deal with pain in the eye. Usually pain in the eye is usually a pretty bad sign, right? Like you should probably go in and get checked out. So if they're administering this to decrease that pain in the eye, and also you worry about chronically having that chronic dry eye or chronically dealing with some abrasions from missing that blink reflex over time. So that's another thing why you wouldn't want to necessarily prescribe that for outpatient use. So really it's going to be more for on the inpatient or in the clinic type setting. We also have some other cycloplegic agents, so these are going to be good for using for fundoscopic exams and whatnot. You can also potentially use it if you're having some ciliary spasm. You can help to relieve some of that. The main medications we're going to be using for this will have kind of two sets. One is going to be the antimuscarinics. So again, we talked about the antimuscarinics are going to have, by blocking those muscarinic receptors, you'll see mydriasis, the pupils open up. And so the agents we'll see used include atropine. So you can have atropine drops. You'll see cyclopentolate. And then also tropicamide is going to be another one as a cycloplegic agent. Again, major adverse effects is that the patient's going to have photosensitivity and blurred vision for some time after getting it. So you really want to make sure they're not going to be driving because, again, it's going to be tough for them to see for some time after they've received the drops. On the other hand, the other class that we can use for similar activity is using our sympathomimetics. And so these are going to be things that are activating the sympathetic nervous system, and these are going to be alpha receptor agonists. So these are actually going to be activating alpha-1 receptors. And so these are going to lead to mydriasis as well, but they tend to be a little bit more reactive to light than you would see with the antimuscarinic. So you tend to have less blurry vision, less profound kind of visual disability after receiving it. The main medication you'll see used here is going to be phenylephrine. Usually brand name is neosynephrine here. Sometimes I'll see the ophthalmologist actually use an antimuscarinic and a sympathomimetic at the same time in order to really get the eye nice and open so they can do whatever exams or whatever they need to do. Major adverse effects you're going to see here include photosensitivity and also some potential for hyperemia in the conjunctiva. Some other diagnostic agents you might see being used include fluorescein. So fluorescein is frequently used. Usually comes like on a kind of a little tiny paper stick you can kind of just dab into the eye. This is going to help to reveal epithelial defects in the cornea and the conjunctiva. So basically you apply this and you use your Woods lamp to be able to see any kind of abrasions that are happening. You can kind of see that there on the slide. Really well tolerated for the most part, and typically the biggest thing you might see is maybe some hypersensitivity and then burning sensation. But again, for a lot of these, you're going to be applying a topical anesthetic prior to this anyway, so probably they shouldn't really be feeling a whole lot of this in the first place. And then we also have another diagnostic agent called Trypan Blue or Vision Blue, and this is really going to be used more in the surgical setting. This is useful for facilitating visualization of the lens, and if they're doing like a vitrectomy, this helps to guide the excision they might be doing. Stain lasts for quite some time, so around a week or so, but it's nice because it helps to collect there. It helps the surgeon out when they're removing this. So again, as far as patient education points go, just remember, wash your hands before and after, because you really want to keep any of these products as sterile as possible between uses. And like we said, the other thing is, wait 5 minutes or so between giving different medications, because you don't want to wash away the first one by giving the other one too soon, right? So especially if they're on multiple anti-glaucoma meds, obviously the best thing to do would be use a combination product. But if you have really uncontrolled glaucoma and you haven't used multiple meds, it's important that you wait that amount of time prior to using them. Right? Okay, so do you guys have any questions before we move on? Okay, the next lecture is going to be bugs and drugs. That's going to be a pretty hefty one. It'll probably bleed over into the following course. But if you have any questions in the meantime, please feel free to email me and we'll go from there. Thanks.
Do you know when you'll get the lectures up on YouTube?
So the first one's already up. I'll post this one up tonight. I put a link in the Blackboard. Yeah, the sound quality actually is pretty good, so I think at least so. But let me know your feedback.